Good morning, everybody. Welcome to this presentation. Dr. Manasi will be presenting a case on CA endometrium. Over to Manasi.
Thank you, ma'am. Good morning, ma'am.
Good morning.
Yeah. So I will start with my case today. 47 years old lady, resident of Thrissur, Kerala, teacher by profession, middle class by socio-economic status, who has a follow-up case of breast carcinoma, comes with a chief complaint of postmenopausal spotting per vaginum since 3 days. No complaint of discharge period of postcoital bleeding or pain in abdomen. No complaint of weight loss or loss of appetite. No complaint of altered bowel bladder habits. No complaint of bilateral chest wall or axillary swelling. Coming to the menstrual history, she attained menopause, surgical menopause at the age of 45 years of age. Obstetric history, para-1 giving one. One LSCS was done 25 years back and she is not sterilized. Past history, no comorbidities. Personal histories, she consumes mixed diet, sleep adequate, bowel bladder habits normal. No addiction, no drug allergy. Patient gives history of pap smear. It has done 2 years back, which was negative. Family history was nil for genital breast, thyroid or GIT malignancy in first or second degree relatives on both maternal as well as paternal sides. Her past treatment history is significant. Patient first was diagnosed with carcinoma left breast in 2005, which was triple negative carcinoma. She underwent chemo and radiation after that. In 2015, patient had right breast carcinoma for which she underwent DCS, and in 2020 also patient recurred in the left breast for which she again underwent DCS. Patient in 2020 her tumor profile was ER/PR positive, so she was started on tamoxifen tablet. She consumed this tablet, and after 1 year patient was patient did have BRCA1 BRCA2 molecular testing, and she had BRCA1 pathogenic variant for which she underwent bilateral mastectomy and RRSO in July 2021. After that, patient started having tablet letrozole 2.5 mg/OD, and now in January 2023, patient presented with postmenopausal bleeding. So her total tamoxifen exposure duration was 1 year. Coming to the summary, 47 years old lady, resident of Thrissur, Kerala, follow-up case of bilateral breast carcinoma, BRCA1 pathogenic variant, status post RRSO, and bilateral mastectomy, with tamoxifen exposure of 1 year, now complaints of postmenopausal spotting per vaginum since 3 days.
Mansi, there's a question in the chat box. Why did you ask for axillary swelling in a CA endometrium? Probably he missed you explain that to them.
Because patient is breast carcinoma patient follow-up case, so I just wanted to rule out any recurrence of local recurrence of the breast.
So I hope the answer is you have written your differential diagnosis, right? So
yes, ma'am.
Are you missing something?
Proceed with the differential diagnosis. Yeah.
Yeah, so differential diagnosis for this case, I would like to put forward first as endometrial carcinoma.
Mansi, hello.
Yes, ma'am. Am I audible? Hello?
Yeah, you're audible.
Okay, ma'am. So endometrial carcinoma, endometrial hyperplasia, endometrial or cervical polyp, carcinoma cervix, and last as metastasis from breast carcinoma.
You should, if you're writing in terms of carcinoma endometrium, should you also write sarcoma? You trying sarcoma here?
Yes, ma'am. Uterine sarcoma can also be a differential diagnosis. 50% of them will be presenting as premenopausal young women with heavy menstrual bleeding. So I did not include it here because this patient is 47 years old and postmenopausal.
She has a risk factor.
But risk factor is there, tamoxifen, that will be in favor of sarcomas also.
Endometrium in a postmenopausal female?
One positive. Hello, am I audible? Hello?
Yes, ma'am.
Hello, ma'am. Yes.
My question is, your patient is BRCA. So, negative or she's positive. I mean, you're giving her letrozole, tamoxifen.
Ma'am, can you please repeat the question? There was little difficulty in. Hello?
Breast case tumor breast. And how?
Ma'am, I am hearing you. There is disturbance in the voice, ma'am. Is it from my side or madam's side? Hello?
See, Mansi, when we started with
now
this,
you are audible, ma'am.
well, she's on tamoxifen. Hello? So we did not mention the differential diagnosis of atrophic endometritis.
Yes, ma'am. Atrophic endometritis I have not put as a differential diagnosis because the patient is having tamoxifen exposure. So, and generally tamoxifen will cause.
The question will be what duration of tamoxifen exposure will pose a patient at increased risk of developing carcinoma or sarcoma. If we to talk in terms of only exposure, is that clear?
Yes, ma'am. So studies say around 2 years of exposure, more than 2 years of exposure will be significant in these cases, and tamoxifen will increase the risk 2 to 7 folds in different studies. It is given that 2 to 7 folds higher risk for causing endometrial carcinoma as compared to the general population. Hello.
In that situation, you have to keep the differential diagnosis of atrophic endometritis as well, right? When it is more than 2 years of exposure with putting them at risk, then atrophic endometritis should be considered, no?
Yes, ma'am.
Now,
Is BRCA mutation increases the risk, Nancy? Whether BRCA mutation?
Yes, ma'am. Recent studies say that BRCA1 specifically pathogenic variant will have 3 to 4% increased risk of endometrial carcinoma.
which variant? And which BRCA? I mean, BRCA1
BRCA1, madam.
And which variant commonly?
Type of endometrial carcinoma, ma'am, you're asking? Serous
Yes,
type or serous or carcinosarcoma?
Correct.
High grade pathology.
Yes, type 2. Right, correct.
Right.
Very well answered. So, shall we proceed? Pooja, do you want to ask something here?
No, ma'am. I would like to hear the examination findings and then we will discuss.
Sure. Go ahead, Mansi.
Yes, ma'am. On clinical examination, general examination, patient conscious, cooperative, well-oriented in time, place, and person. Eco performance status 0. She was well-built, moderately nourished. Height 152 centimeter, weight 65 kg, BMI being 28 kg per meter square. She was febrile, pulse being 90 beats per minute, and blood pressure 130 by 86 millimeter of mercury in sitting position. No pallor icterus, cyanosis, bilateral pedal edema, clubbing or lymphadenopathy. Bilateral chest wall and axilla, no abnormality detected. Thyroid exam was normal. On systemic examination, RS, bilateral equal air entry, and no added sounds were heard. On cardiovascular system, S1, S2 were heard, and no murmur was heard. For abdominal examination on inspection, no abdominal distension, financial scar was seen, no visible peristalsis or dilated veins, umbilicus central and inverted. On palpation, soft, no guarding rigidity, tenderness, no organomegaly, no ascites. External genitalia, vulva and vaginal orifice appears normal. For speculum examination, cervix healthy, vaginal walls healthy, no evidence of spotting or discharge. Bimanual examination, uterus retroverted, bulky, mobile, bilateral fornices free, non-tender. Retrovaginal examination, uh, bilateral parametria free, rectal mucosa was free. Coming to the summary, 47 years old lady, resident of Thrissur, Kerala, follow-up case of bilateral breast carcinoma, BRCA1 pathogenic variant, status post RRSO and bilateral mastectomy, with tamoxifen exposure of 1 year, now complaints of postmenopausal spotting per vaginal since 3 days, and ECOG performance status being 0. On examination, there is bulky mobile uterus.
How will you evaluate this patient further?
Ma'am, I would like to evaluate this patient with diagnostic I will divide the investigations into diagnostic investigation first. So I would like to proceed with same setting, pipel biopsy. And as well as I will send baseline.
Differ here. Straight away you're going in for biopsy without even checking the ultrasound. I mean, will that be justified, or would you like to once again follow the same track that first we triage them using a TVS and then we go ahead with further evaluation? Because going ahead with biopsy only, she could be a polyp inside. So then, in that case, you should club it with hysteroscopy in the same setting, preferably. Do you understand, Mansi?
Yes.
So, now reply the question.
Yes, since it's a recommendation in postmenopausal bleeding, we have to evaluate the patient, and it depends on the setting. If office hysteroscopy is available, it will be best to use office hysteroscopy and then take the biopsy. If it is not available and if there is easy availability of USG, then I would like to extend my clinical examination with USG and then followed by pipel biopsy. But if the in the institution it takes time for the USG follow-up, then I would like to prefer pipel biopsy first. So it depends on the availability of the USG office hysteroscopy.
No, listen, Mansi. Now, this is getting confused for us because see, try and understand when you're replying for these questions in the exam, you have to understand that things are available to you. If we go into non-availability of your options, then it is very difficult to understand the protocols to go ahead. If your things are not available, then these are adjustments which you will as such do, and you'll find out the alternatives in your systems. So when we are answering in the exam, so always assume that you have the things. It is always assumed, not that you will find out an alternative that USG is not available. USG is a basic thing. A patient who is post CA breast mastectomy, tamoxifen exposure, BRCA1 positive, will not go to a center where it is a village and you will not deal with them. Right? You are an MCH or the NDRNB candidate. You are sitting there, so you will be there when you are there, and a USG will definitely be there, to my assumption. So the question was that you will straight away go in for EB, or you will triage with a scan, or you will do a scan. That was the question actually.
Yeah, if everything is available, I would like best will be hysteroscopic guided DNC, madam, in this case, so that we will understand
Madam is saying that based on the ultrasound findings, you have to decide whether you can take pipel biopsy directly or you have to do hysteroscopy and biopsy, because if the endometrial thickness is like it is very high, then there is possibility of polyp, and in case of polyp, you are not going to get any biopsy specimen just by doing pipel.
Yes.
So first of all, in any case of postmenopausal bleeding, nothing stops you from doing a TVS ultrasound. TVS first. Whatever is the situation, she's a known case of CA breast survivor. She has already undergone surgeries. So you will do a TVS. See, look at the ultrasound picture. You will check for the status of any other adnexal mass or anything inside. And then you will go in for a biopsy. She could be sarcoma, she could be anything.
Yes, yes. And Dr. Seema, this is discussed in so many of our discussions. And recently also, Dr. Amita, and I think in cancer centers, the office ultrasounds are not available. So they are of opinion that even I prefer an ultrasound and then go ahead with the.
Ma'am, in this forum, there are many students available. I mean, we have a lot of MD students also here in this session.
Yeah, but then
We will
personally I prefer, but all are objecting that patient cannot come back for the PPD sampling.
Ma'am, TVS is just an extension of your PV examination.
Ultrasound is an extension, but in most of the cancer centers, the ultrasoundologists are doing that. So office ultrasound is not available. But most of the patients comes with an ultrasound, and if the polyp is friable, always you can get it with a PPD sampling. If it's not friable, that means it may not be. But then we have to resort to hysteroscopy. So I personally prefer a ultrasound and then decide for the PPD sampling.
So for the students who are here in this forum, they have to understand that any patient.
What is your opinion? Then you can will accordingly proceed.
They will be triaging. Ma'am, let's not get fixed up here. Yeah. We have a lot of DRNB students who will be writing this question in their exam, management of postmenopausal bleeding, who will be answering this question in their exams. We cannot tell them this option. They have to remember that they have to triage all the patients of postmenopausal bleeding with a TVS. So please don't, whatever is happening at NC center or whatever is happening at one or the particular.
All the national faculties are feeling in the opposite way. So that is why, because recently also, last week also.
Okay, let us not defend her. She's not, nobody is right or wrong. I'm just telling for the sake of benefit of other 100 students.
Because of your opinion, maybe better for the DRNB students. That's what I'm telling.
So let us proceed further.
Yeah.
Yes, madam. So depending on the pupil biopsy result, I would like to face my further evaluation, ma'am. Also, I would send baseline investigations, blood investigations such as complete blood count, renal function test, liver function test.
Okay, what is the accuracy of pupil biopsy for diagnosing CA endometrium?
Yes, ma'am. Pupil biopsy accuracy for diagnosing CA endometrium in postmenopausal women, it is 99% and above. In premenopausal women, it is 91% and above. This is the sensitivity I'm saying, and specificity is also around 85 to 90%. So we can go ahead with pupil biopsy, and we can rely on the results.
Okay, if the biopsy comes out to be negative for this patient, then how will you proceed further?
If the pupil biopsy comes negative, I would like to know the USG finding. On USG, the endometrial thickness was significant, and patient is having postmenopausal bleeding. Pupil biopsy comes as negative. I would like to wait and keep the patient in close follow-up.
You were right previously that you have to check the USG findings also. If suppose it is less than 4 millimeters and the biopsy has come out to be negative and the patient is asymptomatic now, then you can wait. But if the patient continues to be having persistent bleeding and the endometrial thickness is high, then you have to plan a repeat biopsy along with hysteroscopy for this patient.
Yes.
And also cervical evaluation. You have to look for the cytology, cervical cytology or HPV. All these things also have to be done side by side simultaneously. Don't forget that there could be a possibility of any other pathology which may be lying inside the cervical canal or somewhere. Even that has to be considered at the stage itself. So it is very important for all of us to remember the possibilities your patients are having. Importance is, see, there will be variations in different opinions, different experiences are there. There's no fixed way of doing things. But the right thing is that, yes, as Dr. Pooja has very rightly pointed out, that there is a possibility that even your biopsy may turn out to be negative. This especially happens in patients who have polyp. So in those patients, if you do an ultrasound assessment and check that it is a polypoidal mass, then you can straight away go in for a hysteroscopy and then polypectomy or guided biopsy from that particular lesion, right? So in that situation, you first have to go back, as you have Mansi already said, that if it is negative, you'll go back and look at the ultrasound finding, and if it was definitely thickened, then you will go with the hysteroscopy and directed biopsy. Now, you understand? So that will always be remembered. And then if it is atrophic, your endometrial thickness is thin, suppose it's 3 millimeter, your patient is still having it, then you should consider it as an atrophic thing, and then you can think of some management for that. So this is how we kind of reach step by step to any of these conditions, which are the causes of postmenopausal bleeding in your patient, right? And then cervical assessment is also to be done right at the same sitting. So what next? Yes, Pooja, please proceed.
Are we supposed to know the biopsy findings, biopsy report of this patient, or we have to proceed without that?
No, we can ask them the biopsy. No problem.
Yes, ma'am. Biopsy report came as endometrial carcinoma grade 1. Endometrioid endometrial carcinoma grade 1.
Okay. How are you going to proceed then? You have the biopsy report, and what next?
Yeah, so since now it is diagnosed CA endometrium, I would like to proceed with metastatic workup. I would like to do MRI pelvis with abdominal screening and HRCT chest for this patient.
Okay, so CT scan of chest is required always for staging purpose?
Not really, ma'am. If it is clinically, as the uterus is freely mobile, and even USG findings are suggestive of like she had only 13 mm ET and no significant lesion, then considering that it is early stage disease, chest X-ray is enough. But as this patient has previous history of bilateral breast carcinoma and multiple times operated for the same, I would like to do HRCT chest because breast carcinoma can also metastasize in the lung.
Yeah, right. Okay, so what are you going to look for in the MRI?
In the MRI, I would like to do, I would like to see the tumor size, site, as well as the parameter, the biometrical invasion. If it is less than 50% or more than 50%, then parametrial involvement is there or not, and cervical stromal invasion is there or not, as well as this is for local extension of the disease, as well as I would like to know whether nodal involvement, lateral pelvic para-aortic nodal involvement are there or not, significant enlargement of the nodes, and also the soft tissue delineation, that is the fat plane between the bladder and the rectum. These are the things, and upper abdomen screening, so that any other tumor deposits in the upper abdomen. These are the things I would like to know from MRI.
Okay. Is MRI mandatory for every patient with CA endometrium, or you can go ahead without doing a MRI with other imaging investigations?
If ultrasound TVS done with the expert sonologist is equally good, ma'am, to know about myometrial invasion and cervical stromal invasion. The sensitivity of TVS is 78%, and with MRI it increases to around 85%. So it is, if it in expert hand, TVS will suffice.
Yes, right. But in cases where you are planning for fertility preservation, then you should definitely try doing MRI if it's available.
Yes.
There is a question here, PET MRI. I mean, question here, so we are asking you, you can reply that question. PET MRI, role of PET MRI in this patient. I mean, somebody is asking, I don't know.
So, PET CT or PET MRI, ma'am, I would like to say that PET CT is the best for nodal metastasis, but as I'm not, at present, I'm not suspecting her to have advanced CA endometrium, I would like to go with only MRI.
I agree with you. I agree with you. Definitely. There's no role of, as such, PET MRI in these patients, such an expensive and such a less readily available test. All these fancy investigations are not needed because the endometrial staging as such is this clinical surgical pathological staging. So we are as such going to pathologically stage the disease, and that will be more relevant. So I don't think we need to go for PET MRI at least. And regarding PET CT also, yes, there is recently some evidence is coming that yes, using PET and using the some values, some parameters during PET, one can find out the prognostic parameters, that it is increased association with endometrioid or serous pathologies or even LVSI. All these things have been investigated, but they're all in the research setting and they're not used practically. So as such, even PET CT is not definitely indicated in your patient. So we don't advise these two investigations in this patient. What Mansi is telling currently is the right way of evaluation of this patient by imaging. Yeah, Mansi, continue.
Yes, ma'am. So, should I present the MRI report here?
Yes, somebody is saying if we are also, but we are also suspecting breast mets. HRCT is being advised.
Yes, ma'am, this is true. But the patient is under regular follow-up for breast carcinoma. Her follow-up is regular for that. And last visit was her 4 months back only. So at that time, there was no evidence of any metastasis. So from the breast as such. And patient is not having any symptoms also of metastasis, like bony metastasis, some bone pain or backache like that.
So yes, definitely there's a doubt here that even if it is a sarcoma, then also will you do the same imaging, or you will advise for some other imaging modality for the patient?
I would go for the same imaging in case of sarcoma.
In that situation, do you think we should advise for a PET CT for this patient? PET CT. I'm not talking of PET MRI. I'm sorry, we don't get. I mean, I don't read through PET MRI, and then also it is not readily available everywhere, and not many people are doing it. So I'll not go for PET MRI. But then, what about the PET CT in case you're suspecting sarcoma?
It depends on the grade of the sarcoma. If it is high grade or leiomyosarcoma or undifferentiated, then I would like to go for PET scan because it is aggressive disease. If it is low grade endometrial stromal sarcoma, I would still go for the same MRI.
Okay, no problem. One have many ways to defend their own decisions, but then yes, she's a CA breast survivor, so PET CT definitely will help you to look at the bones and everything correctly. So as people have raised this point, so this point is also very valid. So it's fine to say if you want to say that I'd like to do a PET CT whole body in this patient because she's a CA breast survivor and is undergoing treatment just 1 year back in BRCA1 pathogenic variant positive, high risk of relapses and all. So it's good, it's okay to go ahead with that. So now let's proceed further. So how will you plan her management now further?
So this is my MRI.
MRI findings?
Yeah.
Yeah, you have already told. Okay.
Yeah, I would like to put forward the MRI findings now. So T2 intermediate signal mass 3.6 into 2.5 into 3.6 centimeter in the endometrial cavity, extending into anterior myometrium, involving more than 50% of the myometrium. There is intense diffusion restriction and post-contrast enhancement. No extension into cervix or parametrium. Left external iliac lymph node 1.2 into 1 centimeter. No enlargement of para-aortic lymph nodes and upper abdomen being normal. These are the images. So this is the first image. This is sagittal view of T2 weighted images. Where we can see this is the uterus, this is the bladder, and this is the jelly, contrast jelly that have been put in the vagina. So we can see the endomyometrial junction on the anterior side is not, it is irregular, it is not distinct. And coming to this second image, here we can see this is the axial image, axial cut. So this is the, again, the anteriorly the endomyometrial junction is not distinct, as but here we can see one external iliac lymph node. So these are external iliac vessels, and this is the lymph node which was measuring 1.2 into 1 centimeter. So these are my findings.
Okay, further, so next, what all will you see? What will you do now? Would you like to do some tumor marker for her?
Tumor marker, actually CA125 correlates with the extrauterine spread of the disease in CA endometrium. But as with these images, I am not expecting extrauterine disease. I will not go for CA125.
So based on imaging, you will decide whether you want to do CA125 or not.
It also depends on clinical examination with imaging. As it is suspected early stage disease, I will not go for CA125.
Okay, then further, how will you proceed?
So according to MRI, it is more than 50% involvement of the the myometrium. So apparently clinically stage 1B disease, and only 1.2 into 1 centimeter lymph node, which is borderline again. So we discussed this with our radiologist, that lymph node was not very prominent for metastasis. So we planned her for upfront surgery, madam. And this patient, as it is uterine confined disease, we can plan her for minimally invasive surgery also. That is lap or robotic, depending on the availability, as well as so type 1 hysterectomy, type 1 hysterectomy with bilateral salpingo-oophorectomy with bilateral.
It's already done. RRSO is already done previously.
Sorry. RRSO is done for this patient. So, hysterectomy with SLNB evaluation. That would be my plan for this patient. Before that, preoperative blood investigations will be evaluated.
So you have number one thing is here that whenever you are saying this, so in exams one has to always start with the preoperative evaluation. They have to mention the investigation. And thereafter you need to go and you need to also talk a little bit about the preoperative optimizations, the consent process, the preoperative arrangements which as a resident or as a team you would like to do, and then a counseling session with the relatives, explaining them the surgical aspects, the surgical expectations, the requirement of further follow-ups. All these things have to be reinforced in the preoperative period, Mansi. So that's when you are answering in your question in your exams, and all these things you are as such doing in your clinics, isn't it?
Yes.
Mentioning, isn't it? So this is what makes your answer more complete, because you're already doing all these things. Okay. So it takes hardly 3-4 minutes, but then it gives an overview that as a surgeon you are more concerned and you are taking the patients for proper preoperative evaluation.
Yes.
Okay. So that is one thing, and then intraoperatively, what precautions will you take? All these things, little bit you should mention, huh? Okay, so you wanted to go for a sentinel node mapping and a hysterectomy preferably minimally invasive, and depending on the availability of the services, right?
Yes.
So we go with that. So in this patient, suppose you are not having any, which platform will you use for the sentinel node mapping?
For sentinel node mapping, the ICG dye, that is orocyanine green dye, with infrared imaging camera, that will be the best mode. Or otherwise, we can use technetium 99 radiocolloid dye, and isosulfan blue, methylene blue. These are also the best results will be given by orocyanine green.
Okay. You will use the ICG mapping and you'll use this. Okay. So in your case, which lymph node did you pick? Which is the most commonly picked up lymph node in sentinel node mapping in C endometrium, and which one did you pick in your case?
So we got external iliac lymph node, ma'am. So most commonly picked up lymph node is external iliac, followed by obturator.
Okay, we agree. I agree with you that yes.
So suppose sentinel lymph node technique is not available wherever you are working, then how will you decide whether you have to go ahead with lymphadenectomy or not, and what should be the extent of lymphadenectomy?
So in such cases, ma'am, if the patient is having stage 1A disease, the chances of lymph node involvement will be 1%. So we can, if we have frozen
You have
section
to also see the
availability,
grade, no?
yeah, grade also. Endometrioid grade 1 with stage 1A, that will have 1% chances of lymph node involvement. If on imaging lymph nodes are normal, not enlarged and all, then in such cases, best thing will be, ma'am, if frozen section availability is there, I would like to send a pH specimen for frozen, and I would like to know what is the myometrial invasion. If it is less than 50%, and no cervical stromal invasion, that means confirm it is stage 1A disease, then we can avoid lymphadenectomy. Otherwise, I would like to do.
I'm sorry, I'll differ here before we go further. How frequently do you send specimen of uterus for frozen section? What are the limitations of frozen section in a C endometrium case? Do you send it routinely for your patients?
No, ma'am.
No.
Then why are you answering this question like this? That you will send a section for the frozen section specimen?
So here we have to know that what is the accuracy of MRI versus frozen section in deciding the myometrial invasion. MRI is a very good investigation. It is quite accurate in predicting the myometrial invasion. So I don't think frozen section is required when you have already done MRI.
Should not be done in the uterine specimen because it distorts the tumor.
Yes.
And your pathologist would hate you if you send it for frozen section. They don't like it at all. It should not be done. And I'm sure it is not a routine at anywhere, at any center for endometrium. It is not done.
Yes.
So you
So in that case, I would do bilateral pelvic lymphadenectomy.
Even for low risk, your patient is grade 1 less than 50% myoinvasion.
No, in those patients I will not do. All other patients I will do.
Okay, fine. The thing is that with the advent of sentinel node mapping, we all should now be going to the sentinel node mapping only. So that is a good thing that she did also. That bilateral sentinel node mapping was tried in this patient, and thereafter you'll take out the sentinel node, and then you will proceed for this thing further. So I want to ask you, how did you do sentinel node mapping in your case exactly? You did an open surgery, that's what I could read in your note. How did you go in for that, and what exactly happened? We just would like to know from you. Yeah.
Yes, sir. So we went with a laparotomy approach, and we have used the technetium 99 diamond. So under anesthesia, we have injected this technetium 99 dye on
Under
3 o'clock.
anesthesia. Under anesthesia, technetium 99 dye. But under anesthesia, which protocol are you using? Not do you do? I mean, you have protocols for the technetium 99, long and short protocols, which is based on hours because the technetium particles will take time to go into the nodes, right? So do you do it on the table or you do it pre-operatively and then do a lymphoscintigraphy and then you come on the table and give a visual dye, I mean the colorimetric dye on that table? I mean, how do you proceed? Just recollect, Bida.
Yeah, no, in our institute, now we will do it under anesthesia. Before starting the procedure, we will inject the dye at 3 o'clock and 9 o'clock position, superficial and deep. That superficial is 2 mm depth and deep is 2 centimeter depth. And then we will start the procedure. We'll open the abdominal layers and we will proceed with TH, BSO, now in this case TH. And after that, we will go for sentinel lymph node evaluation.
Well, I'm sorry here that Pooja, you are there, right?
Yes.
I mean, to my understanding, it doesn't work this way because we cannot do a hysterectomy first before mapping for the sentinel node. Can we do that, Pooja?
Ma'am, if we are using this technetium dye, then as per my knowledge, it has to be done before the.
Even if you use ICG, you cannot disrupt the lymphatics before mapping them.
Yeah, if we are using ICG, then we have to do the sentinel node mapping before removing.
Yeah, for everything, for every procedure, for everything. I mean, see, there are different ways of mapping the nodes. It's okay. It doesn't matter. There are different protocols at different places. Let us understand the principle of sentinel node mapping will be that we inject the dye. It follows a track of lymphatics and it gets settled down in the node, right? And then we pick up these nodes by any of the modalities, whether it be your gamma camera or is it be a infrared technique, anything, so there are different ways with the gamma camera. The better protocols, there are many protocols available, the long protocols and the short protocols, because the size of the technetium particles, it takes time, it is different, and the dose is different. So you, depending on that, the time which you have for your surgery, suppose you're taking your case as a first case and you are giving it a day before, then you can use a long protocol. And if you're taking the second case, then you can give it in the morning and you can use a short protocol in that condition. And then it is always better to do a scanning, a lymphoscintigraphy, which is done and then which picks up your hot nodes there, and then you can correlate with your gamma camera, the gamma probe to pick up this node. So this is how it is done, and this is done before hysterectomy preferably. That's what we do, and I have read it also this only. I'm not sure, because once you do a hysterectomy, you are already disrupting the channels of lymphatics, and then this may kind of interfere with your mapping, to my understanding. But then we have other faculties also. I think Dr. Rupinder ma'am is here. Navneet ji, can we make her a panelist here? So that would be useful for the discussion. We had a message comment from ma'am in the chat box as well. So you do mapping using any technology, whether it is technetium 99, whether it is ICG camera, depending on the platform you have. And sometimes you use dual staining. Dual staining is you use one of these things, like either you use technetium or use ICG, plus you can use a blue dye as well. So this will help you to delineate on the table, right? So this is how sentinel node mapping we do. It's okay. So in your case, you found out external iliac lymph node on one side, and one side it was a failed mapping, right, Pansi?
Yes.
So you find failed mapping. Do so. What is recommended? What is recommended when you have a failed mapping, and what could be the reasons for failed mapping?
Okay. So, ma'am, if one-sided mapping is failed, that means we cannot detect the SLNV on one side. The reasons can be first the wrong technique of injecting the dye, or second reason can be that the common places where we search for lymph nodes, maybe there are three pathways of the lymphatic channels. So maybe the uncommon pathways such as presacral lymph nodes or para-aortic lymph nodes isolated, they can be they have to be evaluated if pelvic lymph nodes are not found as SLNB not detected in pelvic site. Then third reason can be if the lymph nodes are grossly involved, then the lymphatic channels are also disturbed. So in that case also, ma'am, we cannot, like the dye will not reach to the lymph node and we will not get SLND in that case also.
Yeah, right. So there can be many reasons where you may not be able to map the sentinel nodes. Yeah. So in that situation, what is the MSKCC algorithm? How do you proceed?
Yes, ma'am. Yes, ma'am. So if we don't see the lymph node, suppose we are doing ICG dye, we cannot see the lymph node, then we will find out the afferent channels, the lymphatic channel, which is showing the fluorescence. And where that channel is entering whichever lymph node, that lymph node we will pick as a SLN. If that is also not there, then we can we will see in the pre-sacral area and paralytic area. If that is also not there, then we can re-inject with ICG and then again see. If on re-injection also we cannot find, then we will go for site-specific lymphadenectomy.
Okay. So you will go for a site. If you are not able to map the nodes on one side, then you go for a site-specific lymphadenectomy. That is right. Yes, it's okay. So in your patient, did you do a site-specific lymphadenectomy?
Yes, ma'am. Left side we did.
Okay. So there's a question in the chat box right here. I'll address because otherwise it will be late. We're already 8:20 ho gaya hai. So there's a question. What are the indications for frozen section to be sent? So here, are you asking for? There are two things. One is endometrium. I think we have already discussed that. And uterine specimen, we're not going to send for frozen, right? We don't send. We should not. Now the lymph nodes. Mansi, would you like to send this lymph node for frozen? That is the next question.
Yes. So in case of endometrial carcinoma, the lymph node positivity, that SLNB positivity, will only help us for the adjuvant treatment decision. So anyways, my intraoperative procedure is not going to change. So I will not send this SLNB for frozen.
Absolutely. We will not send this lymph. And on the other hand, yes, ma'am.
And prognosis, yeah.
Yeah, so that's absolutely correct. If you are already standardized your technology of mapping, if you are sure about your mapping, then you need not do anything and you just send this lymph node for final histology and ultrastaging. Correct. So on the other hand, in the cases of cervix, it makes a difference. It does make a difference. Yes. Patients we do send for frozen, right?
Yes.
So that's right. And with frozen, you will not do ultrastaging is not done. So you have to ensure that ultrastaging is done later. They will just check for the macrometastasis over there. So this is, you have to remember that. And somebody is now asking you, are you going to excise the enlarged lymph node? Answer it, Mansi.
Yes. So in the SLNB protocol, we will always excise the enlarged lymph nodes, pelvic or parallel. So I would like to take out the enlarged lymph nodes.
Pooja, please proceed further.
Okay, so after we have completed the surgery, what was the final histopathology report?
Yeah. So coming to the final histopathology report, it came as endometrioid carcinoma, FIGO grade 1. Myometrial invasion was 80%. Lower uterine segment cervical stroma or bilateral parametrium was not involved. There was no substantial LGSI. However, right pelvic sentinel lymph node showed metastatic carcinoma and left pelvic lymph nodes, 1 out of 8 showed metastatic carcinoma. There was no extranodal extension. So the FIGO staging is stage 3C1.
So left-sided, it is positive. So you had your MRI
both sides positive.
Both sided. Both sided lymph nodes. One lymph node came positive.
Exactly. So this both-sided positive. So this itself shows that yes, the need you did this is more than 50% myometrial invasion. You know, there's almost whole thickness is involved. 80% invasion. So only serosa was left probably, and so probably that is what is the risk of lymph node. The next question that you may be asked here is that what is the probability of nodal involvement in stage 1B disease as such, the pelvic and para-aortic?
Yes, ma'am. In stage 1B, it is 8% involvement chances of the nodal metastasis.
I mean, this is the answer should maybe further redrafted based on grades. You will decide if it is.
Sorry, again I forgot.
Yeah, please do that then. So as a postgraduate student, you need to remember that if to do. Okay. So and then of course you have not written very well pointed out. Somebody has pointed it out nicely that you've not mentioned molecular testing. So would you like to add something here?
Any markers?
Yeah, would you like to add something? If you have not done, then you will write. Will you like to mention that molecular not staged or something, or you will like to do some molecular markers here? Right, very important.
Yeah. In case of stage 3 and further stage 3, stage 4, anyways, the adjuvant treatment will be, as they fall in high risk category of ESGO stratification, and treatment will be as chemo RT. So anyways, the treatment will not change depending on the molecular classification. So in this case, I would not like to do molecular staging. We can do it for data collection purpose. ESGO recommends that, but it will not hamper the adjuvant treatment decision.
What basically she's wanting to say that as a routine in their hospital, if histopathology is not doing it molecular classification, then based on this report, she would not advise for doing it. But as such, when you are sending your specimen, so it should be an integral practice that we should do for a molecular classification, right? Right, Mansi? You mean that?
Oh, yes.
So fine. So now she
will help in prognostication also.
Further follow-up, further prognostication. Suppose she's MMR positive, deficient, then in those situations, you may in some setting, because she's stage 3 already, stage 3C1 she already is, right? So in that situation. So and one more question I would like to ask you here. So she is one-sided failed mapping. In that failed mapping area, in that situation, what is the probability of having us missing the para-aortic node? Yeah, somebody has already asked also this question.
I will. Can you repeat, ma'am?
The question was that you have already there's a missed. Sentinel node mapping was failed on one side, right?
Yes.
And she has positive pelvic also eventually. So what is the probability for us missing para-aortic nodes? Because we didn't sample para-aortic nodes for her.
Yes. We have not sampled para-aortic nodes. So when pelvic lymph nodes are positive,
we can't use the word sampling. We have not dissected her para-aortics, right?
Okay. Yes. So when pelvic nodes are positive, 50% of the cases para-aortic lymph nodes can be positive. Micrometastasis.
So now, so fine. So we have missed that part. Anyways, does the pole testing is of prognostic importance for this case? That is the question they're asking. In this case, even if she's polly positive, then it is not currently utilized for de-escalation of treatment. Right? So as such, it is not affecting her. That is why probably she's saying this, that now she would not like to do it for her in the current situation. But as such, when you are sending the specimen, it is a good idea nowadays to go in for a complete molecular profile. And in that case, if she's positive, poly positive, then definitely we can prognosticate her that she's likely to have somewhat better prognosis than her other counterparts, which are poly negative for this group. So, but then currently, because of the lack of enough evidence, we are not going to de-escalate her treatment. Right? So this is how we can counsel this patient.
Okay, what will be the extent of radiation therapy for this patient?
Yes, ma'am. I would like to go for EBRT with that is external beam radiotherapy with extended field radiation involving the para-aortic region up to the renal vessels, and along with the vaginal brachytherapy. So external beam radiotherapy will be given as it was given as 50 grays in 25 fractions, 2 fractions per day for 5 days a week, and VBT was given as 4 gray per 3 fractions, 4 gray per fraction for 3 fractions.
And chemo?
Yes, ma'am. And adjuvant chemotherapy, carboplatin plus
which protocol are you using for adjuvant chemotherapy in these patients? I mean, which protocol are you using here? You're not using chemo radiation for these patients, kya?
Yeah, we do use chemo radiation for these patients, ma'am. Chemo radiation protocol.
So what is your protocol? What did you use in your patient? You didn't tell us that you will use chemo in a...
no, as the question asked by madam was radiotherapy, about radiotherapy.
No, madam is asking you. No, Mansi, please. Madam is asking you what adjuvant treatment will you give her. So in that situation, your complete answer. So, you can't say that madam will ask you that you have given chemo, then you will tell us. It is not right.
No. Yes. Ma'am, so for stage 3, as ESGO stratification is high risk, I would like to go for chemo plus radiotherapy in this patient. And chemotherapy will be given as carboplatin plus paclitaxel. Carboplatin AUC 5 or 6.
What is the protocol and then what you are using? Probably they are...
Yes.
What is the role of concurrent chemo?
Yes. So in PORTIC protocol, they have given radiotherapy first with cisplatin 50 mg per meter square as on day 1 and day 29 as a radiosensitizer. And after radiotherapy, they go for 4 cycles of carbo plus pacli. But in our institution, we give chemotherapy first and then we go for radiotherapy, ma'am. As a part of institutional protocol.
So, okay, there are different ways of giving adjuvant therapy in women with CA endometrium. Somebody may use sandwich therapy, somebody may use the PORTIC protocol, but definitely in cases, most of the studies are using PORTIC protocol. So, better to remember that for the trainees' benefit, that the whatever... So is there any role of now okay, so how will you follow up this patient?
In the follow-up, I would like to visits will be scheduled as 3 monthly for first, as it is a stage 3 disease. I would like to post her at 3 monthly for first 3 years, followed by 6 monthly visits till 5 years, and then annual visits, ma'am. At the time of each visit, I would like to do a clinical examination, and since nodal involvement is there, I would like to do 6 monthly CT scan for this patient.
You will go for CT scan every 6 months for this patient. Every 6 months, irrespective of symptoms, for CT scan for this patient.
Not CT scan. I would say imaging. USG will be enough.
Imaging will be based on the clinical findings, her history, as well as on the examination findings.
Yeah. In ESMO guidelines 2022, they have mentioned that if nodal metastasis is there in the primary surgery, then for first 2 to 3 years, we should go for imaging 6 months. Otherwise, as per the TOTEM study, we can just base the imaging as per the clinical examination and symptoms given by the patient.
Okay, agreed.
Any role for the PARP inhibitors for the PGs? You can just answer for this. Any studies on PARP inhibitors on CA endometrium? There are studies, but not approved. But since she is a case of CA breast also, you can think of that.
Yeah, we can consider BRCA1 positive HEVO patient, so it can be considered, yes, but depending on all those factors, right? But in C endometrium per se, there's not much evidence available to us, right?
Yeah.
So, right, that's fine, ma'am. Now, I think with this, we can now, conclude this session. Can we? Because time is already up. So, Pooja, would you like to ask some questions or any comments or anything you would like to convey some message to the trainees?
It was very good discussion, very good case presentation from Mansi. And
Thank you.
I think we should end this session because it's already 8:30. So
Dr. Chitara, would you like to
thank you.
say something?
Yeah, thank you, Dr. Seema and Dr. Pooja, for the excellent discussion, and thank you for giving us the opportunity.
Yeah, sure.